Thank you very much. I'm going to take you from China to Africa. Before I start, I would like to thank the workshop organizers for inviting Rwanda to share experience and to learn from this great audience. My presentation will not be long, just talk about HIV epidemic in Rwanda, national response and strategies we have to put in place treatment as prevention, and of course we have challenges that we share with you. Let me first start with just a quick course on geography, because now in the room there's people who do not know where is Rwanda. So Rwanda is just in the heart of Africa, as we say. So you can see where I traveled from to come up to here. It's a long way of about 2 days, but I was pleased to come and talk about what we do. We have a very small country. We used to compare it to the state of Maryland because it's the same size. And there's a number of people, 11 points, soon will be 12 million. The country has many hills, and we call it country of 1,000 hills. And it's not very rich. You see the GDP of 644, but it's growing. In terms of HIV epidemic, we have around 200,000 people living with HIV, and those receiving treatments according to eligibility criteria we'll be talking about is more than 90%, and we have more women living with HIV on treatment than men. But we recorded an important data that I want to share with you, that over the last 10 years, we have seen the incidence of HIV declining about 50%, and the mortality related to HIV also about 80% reduced. The HIV epidemic has not been changing a lot if you talk about prevalence, because the two demographic health surveys that we compared, 2005 and 2010, the prevalence remained at 3%. The same similar figures between different groups, population. But we noted an important information here, that the peak of prevalence is still high among women 35 to 39 years old, and for men 40 to 45 years old. And this helps us to set up strategies accordingly. I want to highlight an important element here. Although the prevalence generally is 3%, we still have special cases, if I can say, key populations where female sex workers' prevalence is 51%. And I've tried to compare it to the other data in the region, and this is the highest in the East African region. And we think, and it's not just a thinking, it's probably true, that most of the infections are coming from here in Rwanda. In terms of HIV knowledge and testing, I would like to highlight here that about 100% of Rwandans know where to get a test, and they know how important it is, but how many go for testing, the second red line. Very few. If you see the different age ranges, only 30 to 39 age and 25, 29 is going for testing. And why? There are many answers you can get, but we think it's the age of marriage, then people just for test, because in couples, they are making their new lives. Let me talk about national HIV response a little bit, because we have a national strategy that is being implemented now, built on 3 pillars. First is to reduce new HIV infections. Second is to keep people living with HIV well alive on treatments. And of course, people having equal opportunities on their status is another priority. We have been implementing different strategies to control the epidemic. Behavior change, we invested a lot, male circumcision, condoms, key population focus, elimination of mother-to-child transmission, and for the moment, I think treatments cannot let be left behind when we talk about prevention. And our main goal, as I said, is to stop new infections, people having opportunities and keeping people alive, well alive. And we have done it in synergy with other sectors, not only health. We have seen good results, as I'm going to show quickly. First, the scale-up of HIV services has been well noted. More than 80% our health facilities are having full package of HIV services. You can see the map here. But you need to note that although you see the coverage is interesting, but remember the 1,000 hills I mentioned, because we still have women traveling like 10 hills to get the health facility, while you can see it just there, but you need to cross like a 10 of hills to get there. Another important data I want to share with you is the testing in antenatal care, pregnant mothers, which is almost 98% we recorded of women coming are tested for HIV. And very importantly is that it's a family approach, so they are coming with their husbands. And we have noted that 84%, that's the country data, of our women are coming with their husbands. This has resulted in interesting results in terms of elimination of HIV transmission mother to child, where we came from 2006, a transmission of 13.7% at 6 weeks to 2.3 last year, and at 18 months from 9.7 to 1.3 transmission. I want to talk a bit about treatments. This is a graph showing how we have moved to the coverage to treatments on ARVs countrywide. From 2004, 25%, and you can see that in 2007 we had reached what we called universal coverage according to WHO definition that time. But remember, these are targets CD4 count. These were 200, and when we shifted to from 200 to 350, we went to 65% coverage. Then we tried to reach again the so-called universal coverage, so we are still 91%. But is it the right figure to say 90% is enough now and go and sleep, say we have reached enough universal coverage? The answer is no, and I'll be talking about it for a few minutes, I tried to put together two figures showing how increased the number of people on treatments over years from 2004 to now, that 118,000 people were receiving treatments, antiretroviral treatments. And you can see other people increasing on treatments. We noted the decline, the decrease of new infections, both among children and adults. This is not a study done, but just a programmatic data routine we collect. But I still believe that there is a relationship between these two data, and I think using treatments as prevention will be one of the tools to get to end AIDS. We don't put people on treatment just because we need to see people responding well on treatment. And this is about the survival probability that is still up above 90% over 90 months. These are data we collected from PEPFAR-supported sites in Rwanda, which is about 50% of the entire country facilities. The same for CD4 responses. We see that the median CD4 at initiation 2004 has doubled 2010, and you can see over the different years that the increase was very well noted. This is a slide showing that the earlier we initiate treatment, the better outcome. But here just want to show that in 2004, more than about 70% of patients were started on treatments at WHO stage 3 and 4 in red line. And now we have 15% starting at late stage. So in blue, those are people who are healthier before they get so many opportunistic infections. And interesting to see that people are healthier and they get treatment for long term without any complication. Let me talk about treatment as prevention strategies that we have in country now. I've showed the coverage we have on treatments more than 90%, but again, CD4 350. We have other programs that we are implementing. We already implemented successfully, like task shifting, clinical mentorship programs that we have. In terms of elimination of mother-child transmission, also the current status is encouraging, and especially the follow-up of children who are exposed and waiting to confirm the status. Also have a strong M&E system web-based called TrackNet. Maybe those who came in Rwanda know about it. So we think with this and with the guidelines changes we have been doing, we can implement something else. These are quickly pictures showing how we moved from the different guidelines, CD4, 200, 350 with staging. In 2011, we took a strong decision to move from what I can call some treatment as prevention steps, where we treated TB, HIV, regardless CD4, HIV positive members of this current couple, children under 5, and hepatitis B and HIV co-infection. This was done even before WHO released these recommendations. And I can see some members of the technical group who were in Rwanda when we took this decision. We also went to option B+ for PMCT, and we added in our guidelines that every clinician who think that his patient needs a treatment for other condition not listed can take the decision. We can't stop them to treat because this is their job. So that is another element. But now, when I received the invitation to come, I insisted to come because we had a similar discussion in my country, because we wanted to update our protocol again according to the evidence that has been said here. And a technical group is meeting in Rwanda for the moment, and we expect to have final decision by August this year to move for the new guidelines. And the questions that we are asking ourselves to respond to is to start antiretroviral treatment to all key populations, at least the one we have in my country. The other question is, do we go for all the people we have HIV tested, or we go gradually according to the other constraints like budget and follow-up, as we say. So we'll confirm and decide, but I want to highlight the challenges that we already faced in initial discussions. The first is funding. The Honorable Minister of Malawi has said it yesterday, but I want to emphasize it again, is the most important challenge we are facing in our countries. Although we have been trying to use efficiently the little money we have, but still you end up by having just money for drugs, and cannot just buy drugs without using them and following how the drugs are working. So the other challenge is how do we test people? Because we still have about 40% people not yet tested. How do we bring them into the program? The follow-up, retention, behavior change, M&E, those are other challenges that have been highlighted in previous presentation. And we think that with these challenges we can take a decision and go, because challenges are not there to stop us to implement programs. To conclude, there's no doubt, there's no debate, I think, around treatment as prevention benefits. It has been clearly supported by data and discussions here. We think that treatment as prevention cannot work alone, so it needs to go together with other strategies that we have been doing. And my country is among other countries that's ready to go for the scale-up. And of course, we look at the challenges to go for it. And the most important element we can't forget is the community involvement. We are happy that we have a strong community involvement in the other health issues in Rwanda so that we can build on that. And I want to say that this is about my country, but I think different countries may have different approaches and characteristics to consider before you go for such decision. I thank you and invite you to my country.